Okay, welcome to the pediatric number 5, and hopefully it's gonna be the last one. So, if you're a 52-hour-old girl with left lateral decubitus view show free air above the liver, okay, and the X-ray of the abdomen shows multiple dilated loops of bowel with paucity of air in the large intestine and rectum, okay. You haven't passed meconium yet. So what's your diagnosis? You're spitting up bilious emesis.
So
Abdomen
it
is
can.
tense and distended.
Okay.
What is that?
So you said describe the X-ray again for me. The
So
X-ray.
so basically that's how you know it. 52-hour did not pass meconium.
Mm-hmm.
Yeah, and there is
The
paucity of
X-ray you said free air.
yeah,
Go ahead.
yeah, the left lateral decubitus shows air above the liver.
Mm-hmm.
Yeah.
Handspring. Is it handspring?
This is meconium ileus.
Meconium. Okay.
Because there is multiple dilated loops of small bowel with large intestine and rectum.
Okay.
So the difference is that Hirschsprung level of obstruction in the rectosigmoid, there was a transition, but the so this is the thing, but the meconium ileus at the ileum obstruction. That's a very important difference. Okay. Now, if you are a 2-year-old girl who, who had a sudden, who's just recovering from upper respiratory tract infection, and then the girl is irritable, lethargic, agitated, and uncooperative. AST, ALT increased, ammonia increased, PT prolonged. CT of the brain shows cerebral edema. So what's your diagnosis here?
PT prolonged.
Yeah.
PTT what? Also elevated.
They didn't give the PTT, just the PT. You just had an upper respiratory tract infection that treated with over-the-counter medication.
Okay.
Yeah.
Rice.
Hmm?
Is it
Yeah.
rice?
Yeah, it's Ray syndrome. That's our present with hepatic encephalopathy picture. Now, if you're a 6-week-old boy who present on physical exam, peristaltic wave are seen over the upper abdomen and an olive-shaped mass is palpated in the right upper quadrant. So how do you
Pyloric
treat that, huh?
stenosis. Okay, so diagnosis pyloric stenosis. Treatment will be to correct any electrolyte abnormalities before you do surgery.
So what electrolyte abnormalities associated with pyloric stenosis?
It's gonna be what do you call it? Metabolic. So hypokalemic, so low potassium, low chloride. All right, metabolic alkalosis.
How about 2-month-old full-term girl she presented for the baby visit. She drinks 5 ounces of standard cold milk-based formula every 4 hours. Okay, the patient is fussy when the formula spills out of her nose and then calms down after burping. Physical exam shows intermittent smiling and cooing. The patient is able to lift her head briefly to 30° while prone. So what's next step in this patient?
So if the patient is growing well, so this might be just a regular, baby spitting,
So
but if the patient is losing weight, so it might be like acid reflux.
yeah,
And
excellent. Yeah, there are physiologic GERD and there is pathologic. Physiologic is asymptomatic, and they call it happy spitter. Treatment just reassure and positioning therapy. And there's pathologic. They have failure to thrive, significant irritability, Sandifer syndrome. Management, you give them thickened feeds, anti-acid therapy, and if severe, you want to do esophageal pH monitoring. Okay, and then you do upper endoscopy.
Okay.
Another thing that causes regurgitation in kids, it's milk protein allergy. That's associated with regurg, vomiting, eczema, bloody stool. Treatment, you just eliminate dairy and soy protein from diet. The third one, last one, is pyloric stenosis. They have projectile non-bilious vomiting, olive-shaped mass in the abdomen, weight loss, dehydration. And treatment, you know that we just talked about. Okay, now it's a good case, very nice one. 3-year-old boy who have an abdominal pain that began several hours ago that comes and goes. The baby holds his belly and screams and draws his legs. Okay. When examined, there is soft abdomen that's tender with voluntary guarding to palpation at the right upper and lower quadrant. FOBT is positive.
Intussusception?
Yeah, excellent. So we do air enema. Now, if you are a 14-year-old boy who have weight loss and erythematous vesicular rash distributed over the extensor surfaces of elbow and knees, what's your diagnosis?
Celiac.
Yeah, excellent. Associated with type 1 diabetes, Down syndrome, selective IgA deficiency, autoimmune thyroiditis, first degree relative with celiac. Symptom, they have GI and extra GI. GI is abdominal pain, nausea, vomiting, diarrhea, flatulence, bloating. Extra GI, short stature, weight loss, iron deficiency, anemia, dermatitis herpetiformis. How do you diagnose it? You diagnose it by increased tissue transglutaminase, AGA, increased anti-endomysial antibody, and duodenal biopsy shows increased intraepithelial lymphocyte and flattened villi. That's about it for celiac. Now, 12-hour-old girl present with a triple bubble sign on X-ray, and she's been vomiting, and subcutaneous fat tissue is minimal. What's your diagnosis? Skin is loose.
Jejunal atresia?
Yeah, perfect. Yeah, that's a jejunal atresia, triple top. Now, if you are a 2-week-old girl who present with a blood-tinged, odorless vaginal discharge.
Oh, that's normal. Estrogen withdrawal from moms.
Yeah, good job. Just reassure. And now, if you're a 15-year-old girl who have a cramping menstruation, okay, that radiate to the thigh, back, okay, the pain usually starts few hours prior to menses and lasts 1 to 2 days after. Exam is fine, like uterus is normal, freely mobile, non-tender.
Dysmenorrhea?
What is it, primary or secondary?
Primary.
Yeah, this is a primary. So there is a difference between primary and secondary dysmenorrhea. There's primary, okay, which is the exam is normal, and the pain is due to release of prostaglandin from endometrium, and that's the clues that start before the menses and last 1 to 2 days after. Secondary amenorrhea could be due to endometriosis, where you see nodularity, uterosacral nodularity and adnexal tenderness, or adenomyosis, where you have uterine tenderness and enlargement. Could be pelvic infection, like where you find cervical motion tenderness, okay, purulent cervical discharge, or it could be uterine leiomyoma, which is uterine contour irregularity. Okay, uterine leiomyoma causes pain due to excessive bleeding. Infection, it's inflammation, that's why it causes pain. Endometriosis and adenomyosis due to ectopic endometrial tissue. When it bleeds, that's how it causes pain. Okay, so that's the pathophysiology of pain. Dysmenorrhea. A very simple question. A 15-year-old girl present with a 3 cm mass in the superior outer quadrant of her right breast.
Okay.
Yeah, what's diagnosed?
Fibroadenoma.
Yeah, usually this is less than 30 years old. Single unilateral mobile, well circumscribed mass. They can have pain or size changes prior to menses. Treatment just reassure for adolescent, and but the people who are older, you just do ultrasound. Okay, that's a fibroadenoma. Now, if you are a 14-year-old girl with short stature, blood pressures increase in upper extremities and low in the lower extremities. So what do you expect the FSH level here?
It will be high.
Yeah, excellent. This is a Turner syndrome. Now, nice case. If you are a 15-year-old girl, on bimanual exam, the vagina feels short and the cervix and uterus are not palpable. Okay, and you haven't started menstruation yet. So what's your diagnosis? Pelvic pelvic ultrasound shows
short ultrasound, short vagina.
Let me give you more clues. Pelvic ultrasound shows 2 normal size ovaries and no uterus. Yeah, so now what do you think?
It depends. It can be either AIS or it can be Mullerian agenesis. If they have like a pubic hair and axillary hair, then it's Mullerian agenesis. But if there is no pubic or axillary hair, I'm gonna go with AIS.
Wow, good job. I like it. Yeah. So this patient has a pubic hair, so it's a Mullerian agenesis. Good job. Now, if you are a 2-day-old boy, okay, and you're breastfeeding poorly with weak latch and suck, on exam you have jaundice, scleral icterus, and large tongue, hoarse cry.
Large tongue?
What causing?
Large tongue and what?
Hoarse cry, jaundice.
So 2 days, weak latch, jaundice, large tongue, hoarse cry. I think this is pathologic. Large tongue. How many things comes with large tongue?
So this is congenital hypothyroidism.
It looks like it, yeah.
Most infants are asymptomatic, but some of them have poor feeding, constipation, jaundice, dry skin, large tongue. Large fontanelles. Okay. The diagnosis, they have high increased TSH, low free T4. So that's why we gotta screen newborns and then give them levothyroxine. This can prevent developmental delay, which is interesting. Now, if you are, especially neuronal development, Now, if you're a 4-year-old girl who had a thick yellow-green nasal discharge, when I examined you, I found thick purulent mucus dripping from the nares and visualized in the posterior oropharynx. Nasal turbinate are red and swollen. Maxillary sinuses are mildly tender. What's next step in management?
This looks like bacterial sinusitis. So you're gonna give the patient antibiotic. You're gonna treat with antibiotics.
Yeah, good job. Yeah, so the criteria for acute bacterial rhinosinusitis, it's either one of the three, okay, anyone. Either persistent symptom more than 10 days without improvement, 1. 2, could be severe symptoms, fever more than 102, purulent nasal discharge, and facial pain more than 3 days, like this patient had. That's the second thing. Third thing, it could be worsening symptoms more than 5 days after improvement of a viral upper respiratory tract infections. It's called double sickening. So any one of those, that's a diagnostic for rhinosinusitis. Okay, good question. If you are a 12-year-old girl who present to the office due to worsening rash in her leg for 4 days. Okay, the size of the rash is the size of a dime but has since grown while raised edge and is increasingly itchy. She recalls that there is another girl who had the same symptoms, bull's eye appearance. So how do you treat that?
So tinea corporis, give a topical exo like clotrimazole.
What is that's the first line, topical antifungal, clotrimazole or terbinafine. What is the second line? Or if it's extensive?
Then you can do Grisio, right? Forvin.
Yeah,
by
or
mouth.
oral antifungal, either oral terbinafine or oral griseofulvin. Then you treat it like tinea capitis. Tinea capitis, you start with oral griseofulvin. So that's the difference. So this is risk factors: is athlete, skin-to-skin contact, humid environment, contact with infected animal like rodent. Presentation: erythematous pruritic patch with centrifugal spread and subsequent central clearing with raised annular border. So that's about it in your corporis ringworm. Now, if you're an 18-month-old boy who with fever and a facial rash, on physical exam, you have painful clear vesicles over erythematous skin on both cheeks, as well as a few scattered lesions with overlying dark red crusting with submandibular lymphadenopathy. So what is that?
Okay, describe the physical exam again for me.
So it's uncomfortable appearing child with numerous painful clear vesicles.
Clear vesicles.
So that's an HSV over another condition, which is over erythematous skin on both cheeks, as well as scattered lesion overlying dark red crusting.
Hepaticum something, eczema, right?
Yeah, eczema herpeticum. It's a painful vesicular rash with a punched out erosions and hemorrhagic crusting. That's really. While other differentials to it, impetigo, it's due to Staph aureus and strep. It's painful, non-pruritic pustules with honey crust. Okay, and molluscum contagiosum, it's a flesh-colored papule with central amplification. So that's a differential, just to know if they give you the other ones. So if you are a 4-month-old Hispanic boy with a flat, non-blanching, non-tender patch over your sacrum and buttock, so how do I treat you?
I think is reassurance
Yeah, good job. This is Mongolian spot, just reassure.
Mm-hmm.
How do you manage prolonged QT?
Prolonged QT in what? What do you mean manage prolonged QT?
Like a 6-year-old boy who had dropped suddenly to the ground and regained consciousness quickly.
Mm-hmm.
When you did the EKG, you found long QT.
Mm-hmm.
So inherited long QT or whatever, like long QT syndrome. So how do you treat
Mm-hmm.
that?
I think I think you check the electrolytes, right? Can be electrolyte abnormalities due to hypokalemia, hypomagnesemia, and yeah, check those first.
Yeah, so this kid has congenital QT syndrome.
Mm-hmm.
So the first thing, so what are the congenital QT syndrome?
You have the Romano, and then you have the something Nisso, lunch, sort whatever, those 2. Mm-hmm.
Yeah, Romano ward, autosomal dominant, and Jervell-Lange-Nielsen syndrome, which is autosomal recessive. So you treat it with a propranolol and pacemaker. That's prevent.
Propranolol and pacemaker.
Yeah, prevent cardiac arrest. What are the other causes of long QT?
The acquired ones.
Yeah.
Yeah, I know you asked me the other time. Yeah, we have the electrolyte abnormalities, hypokalemia, hypomagnesemia, hypocalcemia. Then also hypothyroidism can cause it, bradycardia, HIV. Then medications can cause it, anti-arrhythmia medications like sotalol, procainamide, I think also amiodarone. Then you have your what do you call it? So arrhythmia, antipsychotic medications, TCAs can cause it, emetic like Zofran, which is ondansetron. Antibiotics can cause it like macrolides, azithromycin, and the azithromycin family. What do you call it? Yeah, I think I've tried. SSRI too.
Good job, yeah. Antipsychotic to TCA.
Mm-hmm.
Fluoroquinolone, macrolide, methadone, oxycodone, ondansetron, quinidine, procainamide, amiodarone, sotalol, flecainide. So those are the things. Flecainide, those are the class 1 antiarrhythmic. It's a use dependent.
Mm-hmm.
So
I think
it's
class 1C or 1.
1C.
Yeah, 1C. Yeah.
So now, if you are a 4-year-old immigrant boy with a blue discoloration of your fingernails, when I examined you, I found perioral cyanosis and systolic murmur along the left sternal border. When you squat, the loudness of the murmur increases. What is your diagnosis?
TOF.
Yeah, this is the trilogy of fallacy. If you are a 5-year-old boy with a grade 2 systolic murmur, heard when the child is lying down and decreases with standing, how do you treat that?
I think this would be like maybe like a flow murmur or something like that. Yeah. So really,
Sure, yeah. So how do you differentiate?
yes, sure.
How do you differentiate benign from pathologic murmur?
I know that all diastolic murmurs are pathologic, so you have to work it up. All diastolic murmur, But systolic, I think grade 1 and grade 2 is more like a physiologic murmur. Anything from grade 3 to 6 is pathological, and you need to work it up.
Yeah, so the benign, the physical examination, that's an important history.
Mm-hmm.
It's normal, everything normal. While pathologic, you may have diaphoresis, fatigue, chest pain, dizziness, family history of sudden death. So that's the thing. The murmur features pathologic is harsh, holosystolic, diastolic, grade 3, increase with standing and valsalva. So that's the thing. You may find other loud fixed split or single S2, decrease or absent femoral pulses. Okay, so this murmur you need to do EKG for hypertrophy, echo for structural abnormality, and consult cardio. While the physiologic is early or mid systolic, grade 1 or 2 intensity, that decrease on standing and valsalva. It's different. Usually low-pitched, musical, pure, or squeaky tone at the left sternal border. They call it Still's murmur. Or it can be high-pitched at the lower upper sternal, left upper sternal border, pulmonary flow murmur. So it's a pure, it's lovely. While the pathologic is harsh, it's worse with standing, valsalva, fixed split, or something nasty. Now, if you are a 1-day-old boy with cyanosis, blood pressure 80/40 in all, and in all 4 extremities, heart rate is 140, your fingertips and oral mucosa are blue, and you have a continuous machine-like murmur. How do I treat you?
I think this one you're going to have to observe, because the patient has a peripheral cyanosis, which is okay, which is normal in a day old. And then the continuous murmur might be PDA. It takes maybe about 2 to 3 days for that to close. So
this guy having a PDA, and I think so you gotta give him prostaglandin E. Okay, because this is cyanosis, 1-day-old cyanosis, fingertips, and because and the pulse ox, maybe if I gave you the pulse ox would be easier. Pulse ox 80% and does not improve.
You should have given it to me.
Yeah, I should have given it to you. Sorry about that. Yeah, the pulse ox is 80% and does not improve with 100% oxygen by face mask.
Okay, you missed that. That's particular information.
Yeah, you see, so this is important. Yeah, good. Yeah, so there are PDA-dependent murmur like coarctation of aorta, transposition of great vessels, hypoplastic left heart syndrome, total anomalous pulmonary venous return, and tricuspid atresia. So these you gotta keep the PDA open.
Okay.
And you gotta avoid the excess inspired oxygen and avoid indomethacin in this patient, okay? Now, if you are a 3-week-old infant with hypoplastic left heart syndrome, you came to the emergency with difficulty feeding and 1 episode of vomiting. On exam, you're afebrile, blood pressure 80/40, heart rate 160, pulse is 80% on room air. There's cyanosis, heart sound is distant. So, what do you think is going on here?
So what it is, it seems like whatever that is keeping the patient alive is closing, either the PDA or the VSD or the ASD, is closing, right?
So I gave you, this one is a is kind of a tough. So left heart, I told you that the heart sounds are distant, and the blood pressure 80/40. So this hypotension, distant heart sound, and distended jugular vein. So they have pericardial effusion. That's causing.
Okay, so tamponade.
Yeah. How do you work up a 3 out of 4 hollow systolic murmur?
Echo.
Yeah, just echo. What heart condition associated with webbed neck, broad chest, widely spaced nipples?
With Turner syndrome.
Yeah, but
coarctation.
Hmm?
Coarctation of aorta. Is that what you're asking me?
Yeah, but
Or
bicuspid, coarctation or bicuspid aortic valve or aortic root dilation. Then they can have any of that. Ouch. Now, good question. If you're a 12-year-old girl with a headache and there's a soft to and fro bruit here at the right costovertebral angle. So
costovertebral angle.
yeah.
Soft bruit.
Yeah, there's something. There's a term. It took me some time to find out about it. When they say to and fro bruit, do you know what does that mean? That means systolic and diastolic, continuous.
Oh, okay.
To and fro, okay. And the right costovertebral angle. One time I remember I missed a very simple PDA case just because I did not know the term to and the fro bruit. Yeah, and she had hypertension. So what is that? What do you think?
Fibromuscular dysplasia.
Wow, smart. Good job, yeah. So you do angiogram, you reveal string of beads appear, sign. Now, if you are a 3-year-old girl with severe oral pain, okay? When I did the culture, I found Staph aureus, strep pathogen. Leukocyte is 55,000. Neutrophil is 90% of them. What's your diagnosis?
Just oral pain with staph and strep. A neutrophil of 90. Is it bacterial something? What is it?
And you had 2 sinus infection, numerous episodes of cellulitis.
Numerous episodes of cellulitis.
Yeah, so what's causing that? So this is leukocyte adhesion deficiency.
Oh, LAD. Okay.
They have recurrent skin and mucosal bacterial infection, omphalitis, periodontitis, no pus, lack of neutrophil at inflammation site, poor wound healing, delayed umbilical cord separation more than 21 days. They have marked peripheral leukocytosis with neutrophilia. So that's a leukocyte adhesion deficiency. Yeah, they say hepatitis B reduce risk of hepatitis B vaccine reduce risk of reduce risk of cancer. Okay, now if you are a 15-year-old boy who have a sudden onset of difficulty breathing for the past 45 minutes, you complain of nausea, colicky abdominal pain, and swollen face. There is an edematous swelling of the face, including the lips, hands, arms, legs, genitals, without a rash. Temperature is 36. Blood pressure and pulse is normal. What is going on here?
Male, shortness of breath, nausea, abdominal pain.
Yeah, on generalized swelling.
Generalized swelling. I don't know if with this information, if I can answer it. I don't know what it is.
This is C1 inhibitor deficiency.
Oh, okay. C1 angio. Okay.
Hereditary angioedema. So sometimes can be dangerous, can cause anaphylaxis, and you gotta give them epinephrine, and that's it. Okay, so what contraindication to rota vaccination?
Contraindication will be intussusception, mecodiverticulum. I think maybe encephalopathy. What else? Yeah, those are the ones I know.
Yeah, anaphylaxis to vaccine ingredients.
Yeah, right.
History of uncorrected mecodiverticulum, intussusception, and SCID. Severe combined immunodeficiency. It's crazy. This kid is dangerous. Double bubble. Not double bubble, bubble baby they call. Okay, and that is the end of the pediatric. Boom.
Finally.
Finally.